Medical misinformation is everywhere. Dr. Mitch is here for straight talk and to give you the truth.
Today I'd like to discuss somatopause. It's a natural physiologic process that's characterized by gradual decline in growth hormone secretion and its downstream mediator, insulin-like growth factor 1. We know it as IGF-1. It typically begins in the mid-30s to 40s, and it progresses with age and affects both men and women equally without the dramatic hormone shifts that are typically seen in transitions like menopause. Now, somatopause, it's not a disease. It's a normal part of aging where the pituitary gland produces less growth hormone, leading to changes in the body's composition, energy levels, and sometimes overall vitality. It's often under-recognized. Symptoms overlap with general aging things, but understanding it, you may help your patients. Unlike menopause, which has a clear endpoint, somatopause is diagnosed based on a combination of clinical symptoms, biochemical tests, and exclusion of other causes with no single definitive marker, though persistently low IGF levels tend to be a key indicator. Now, to identify if someone may be experiencing somatopause, start by listening to common complaints like subtly over time they occur, fatigue, low energy, not enough adequate rest, reduced muscle mass, strength, even with regular activity, increased body fat around the abdomen, which can contribute to these metabolic issues like insulin resistance, decreased bone mineral density, and leading to some fracture risk. Patients may also report mood alterations like irritability, anxiety, or mild depression, cognitive, dysfunction, and difficulties with concentration, sleep, frequent awakenings, thinning skin, slower wound healing. You get it. Pretty much even a drop in libido and sexual function can ensue with this. Now, physical signs could include reduced exercise tolerance, joint stiffness, even subtle changes in height because of vertebral compression from bone loss. Now, to confirm it, encourage tracking these issues, journal it over time, write it in your notes as you see these patients, more pronounced after 50, and lifestyle factors like chronic stress, poor nutrition, obesity, lack of physical activity is going to accelerate the decline. Now, diagnostic tools will include blood tests for serum IGF-1 levels, and they're much better than growth hormone, which is often below. Growth hormone's tricky to measure it because it's pulsatile release. You're going to miss it. And it's always going to look like it's less than 10. Arginine stimulation could do it, but it could be dangerous and usually needs to be done in an emergency room situation. Imaging like MRI may rule out pituitary tumors if you think. Body composition analysis like bioimpedance may help support your data. But if these signs point to somatopause and impact daily functioning, then you can explore some strategies for management, lifestyle interventions, including resistance training to naturally boost growth hormone, a protein-rich diet, some growth hormone peak things, recombinant growth hormone therapy, but I don't routinely recommend that. You can use other less problematic secretagogues, such as these different types of protein injections, these polyproteins, and of course presence of this particular growth hormone that we'll see, or elevated IGF-1 in breast and prostate cancer, and especially in its propagation, should make you stop and think about using growth hormone and the secretagogues, which are much less problematic because they increase actually the cells or the somatotroph, much less dangerous, much more physiologic. So anyway, ultimately, somatopause is an opportunity to promote healthy aging. Recognize it early, find it, create a good program for these patients, stay vigilant in this area, and gracefully aging, help these patients by optimization, not reversal. Keep and watch for these things. You can make a huge difference in these folks' lives. Thank you so much for watching.